Yes.
Yep. So my name's, I'm Kevin Snow. I'm a physician assistant. I work for Great Plains Orthopedics. This is Dr. Missy Rashid. She's upper extremity, one of our upper extremity surgeons. So we're going to kind of show you some splinting stuff that we would like you guys to learn these techniques and to use. And then also today, if you have any questions, something you've always wondered about this, please ask us. We would love to show you, and because we would like you guys to be very confident in the splints that you're putting on and sending out your patients. You guys, for the most part, do a great job, but there's a few times, and I know you guys all know, it's because you haven't been trained and you don't know. So don't hesitate to ask questions. We'll stop in the middle and answer any questions you want. So I think Dr. Rashid's first going to go. She's going to go first and show upper extremity splint.
Yeah.
So
okay. So I'm essentially going to start from the fingertips and kind of go all the way up because it's all relevant. And I was looking through your box here, and you guys have actually a lot of really easy splints. The most common fingertip splints, I think, what I see coming in are these alumifoam splints, and these are great, except the foam actually can get moist and can macerate the fingers, especially if there's a laceration or a crush injury. So as long as the fingertip is actually kind of well padded with gauze or Curlex or whatever you have, that would be helpful. But you only need to splint the stuff that is broken. So sometimes what I see is like, if they have like a small fingertip injury or like a distal phalanx or a little mallet injury, the whole finger or a couple fingers are splinted. Really, you only need to be here. And actually, those particular injuries are these are great. Do you guys use these?
So I will tell you, I just don't know how to secure them.
Okay, so this is a stack splint. So these are great for any crush injuries. You know what mallet injuries, bony mallet injuries. So anything that involves like an extensor tendon, if the bone's involved or not involved, if there's an extensor lag, these are great. And what we do with these, especially for mallet injuries, is just slide it on. You want to be able to see the fingertip and the fingernail. And all you really need to do is tape it around here, keeping the PIP joint free. So it's only immobilizing the distal interphalangeal joint, this joint here. And it's great for comfort. It's great. I like these splints for mallet injuries because they hold the finger in extension better than those. So any sort of mallet injury, I love it when patients come in with these because I'm like, perfect, you're already, halfway there. And sometimes with mallet injuries, I tell patients like, you can take it off to wash it, but you want to support the finger on something like yourself or like a table, because every time you let the finger droop, it pulls the tendon back away from the bone and doesn't let it heal. So a vast majority of mallet injuries we can treat with this splint alone for like 4 weeks. So this splint is great. I like these splints better than those. But these have some purpose too. These aren't bad for like more proximal finger injuries, like proximal phalanx, like you've got a if you have a single, like small finger proximal phalanx injury, these aren't bad for that. One of the things I do with these though, and I'll kind of look on the longer ones, is instead of keeping the entire finger straight, I put a little bit of a bend in it so that it's more anatomic. The MCP joints like to be splinted in a little bit of flexion. And most fractures are, at the base of the proximal phalanx tend to be angulated dorsally. So putting in a little bit of flexion and securing it that way is, number one, it's more comfortable. Number two, it's better for the fracture. Makes sense?
Yeah.
What else? Anytime there's multiple finger fractures, then I get away from this, and we're starting to talk about more of a one step. Try to think of any other fingertip injuries I'm missing.
I guess if you could just your fingertip, you're saying like a crush or something just to protect them.
Right. So
they don't need to wrap. If you're putting a finger in here, you don't need to wrap it with anything. You just need to tape it and tell them to wear it pretty much until they follow.
Right.
Or protect it.
Yeah.
Whereas this if the patient's not gonna follow up right away, this padding can start to break down and macerate the finger. So if you wrap it, you can wrap it with a little Curlex or web roll, even just to protect the skin. If they have a wound on there too, on the tip of their finger or their hand, and they want you to put them in there, I would wrap it with a nice dressing and just incorporate this, right? I mean, that's what you would do.
Yeah.
If they have a laceration or
Yes,
something.
yeah, just really make sure
Close
that.
with the fracture or something.
So if we're talking about either thumb fractures, more than like distal phalanx, like proximal phalanx, any sort of thumb, metacarpal, any metacarpal fractures or fingers, we're starting to talk more about a forearm-based splint as opposed to a hand or finger-based splint. So I guess I'll start with a thumb spica, and then we'll do a volar splint, and then an ulnar gutter splint. So for, I guess, no, well, just, okay. Because you guys don't have that much web roll. We don't want to like open everything, then you guys have trouble.
You're okay opening any splints. We have plenty of those
Just
with
the
the
web
web
roll.
rolls. They're
Yeah,
kinda hard to
Okay,
get.
really?
Yeah.
Okay. One step's not bad. Your one step is actually nice. Some of the stuff that we get in the ER is a little bit not as good, but so let's say there's like either a proximal phalanx fracture, a metacarpal, even like scaphoid fractures or some sort of radial sort of wrist injury. The thumb spica splint is probably the way to go. And what I do typically is kind of measure. You don't have to go all the way up. I'll cut it. So I cut it before I wet it. Yeah. This is hard to cut anyway. Thank you. Okay. Then the other thing I do is the fiberglass that's in here, it gets hard and it gets sharp against the patient's skin. So a lot of times I'll just kind of fold it underneath the cotton so it's not sticking out against the patient's skin. And then with this stuff is really well padded, so you don't have to go crazy with your web roll or Curlex or whatever else.
As long as you put the padded side
Down, correct.
down.
Yes. So there's like the fiberglass side and then there's a padded side. You always want the padded side down. So typically, let's pretend this is web roll, because I don't want to waste yours. So you're only immobilizing the fingers that need to be immobilized. That's another thing I think we see sometimes is that everything's immobilized, and that doesn't need to happen, especially with a dominant extremity. So right now with the thumb spica, I'm keeping all of the fingers free. I'm keeping the web roll up to the MC or the distal palmar crease because that's where the MCP joints flex. So that way they're able to flex all of their fingers. So I'm only immobilizing the thumb. I'm only wrapping the thumb. I'm putting the padded side down. Wet it. And then really just an ace bandage over it. The other thing about ace bandages, they don't have to be super tight because there's going to be swelling that occurs over the course of 24 hours. So literally, you don't want to stretch it at all. You just want to wrap it. That's it. Just wrapping it. It's not my prettiest looking splint, but it'll work. So going like around the thumb. And essentially, and the other thing I do is kind of the mold. So you're molding it around the thumb, you're molding it into the palm so that the wrist is in a little bit of extension, and then you're kind of securing the thumb. So that's essentially the thumb spike, and he's able to move his fingers.
That's super important.
Moving fingers.
You don't want to get it wrapped up there and get them squeezing or anything like that.
Yeah.
So a lot of times providers aren't in the room when we're putting splints on. Can you go over like pressure areas that are most common for where they need to pad the best on any of these?
So with the one step, it's hard to really over pressurize it. And it's hard to really get a good mold with this. Like as a surgeon, I don't use the stuff. I use plaster because you can get a really decent mold on it if you want to splint it. But I mean, just gentle, just kind of uniform pressure all the way down the splint just to kind of help immobilize it so that it doesn't have to be like You know, it's not holding some sort of reduction. It's just keeping it still for comfort. So that's the thumb spica.
For size reference, I view like a lot of the times when I see other people, they're unsure of how wide to go.
Yeah.
And so for it to be mobilized up here.
So
Yeah.
it should be more like that.
Okay.
Yeah.
Okay.
So for an adult, most of the time you're either going to use a 4-inch or a 3-inch. I wouldn't for hand wrist, I wouldn't go more than that. The ulnar gutter, same sort of principle. So for almost all ulnar gutters, you want to mobilize the ring and the small finger. Even if it's just a small finger injury, you want to mobilize both because they have a common tendon. So an ulnar gutter, I wrap the web roll all the way up.
So it'd be like a boxer's fracture.
It's a boxer's fracture. Even though it's just the small finger attached to that metacarpal, you want to mobilize both the ring and small.
Do you recommend anything in between those fingers then?
You can, yeah. Sometimes just putting a little 4x4 or whatever.
You can put Weberl back and forth, make a little, and then you can slide them in between.
Yeah, especially if there's, you know, lacerations or kind of abrasions, it's not a bad idea. Again, put your 1-step on.
Yeah.
Thanks. Not super tight on the ace wrap. A lot of times for my ulnar gutters, I use usually a 3-inch or a 4-inch ace, and then I'll use a 2-inch because it goes around the ace wrap, or it goes around the fingers a little bit better. I'm not making this look pretty.
And usually in the arm, no more than 2 ace wraps. Sometimes that people like, and there'll be 4 or 5 ace wraps on. You don't need to put that many on.
So again, with the ulnar gutter, I'm leaving the thumb, the index, and the long finger free. And then, so when you're splinting hands, wrists, and fingers, the wrist likes to be in a little bit of an extension. The MCP joints like to be flexed, and the IP joints of the fingers like to be in extension. That's a safe position for the fingers. Now, for you getting them here to the office, it usually is not a huge deal, but for me, when I'm splinting after surgery, that's important because otherwise they could get really stiff and it just inhibits therapy and getting them back to where they need to be. So that's the ulnar gutter. And then the volar splint, I'll just I won't rewrap them up too much, but volar splint's probably the most common one you guys do. Am I wrong? Yeah.
Can I ask you,
Yeah.
the 4th MCP, that should be an ulnar gutter?
Yes.
Is that correct? A volar is not going to.
No, I'd like an ulnar gutter with that.
Same with the 2nd MCP, that was.
So if you have a second
Would
or
that be
third,
the thumb spike in that, or would you
No,
want for the second?
you could do a radial gutter.
Okay,
So instead of the ulnar gutter, which is the 4th and 5th, with the ring and the small, the radial gutter, you need a smaller, like a 3-inch. And then you immobilize just the index and the long down.
Okay.
And you leave these 3.
okay.
It's a little bit of a harder splint, but you can do it. Typically, I'll be honest, a fracture that involves the 2nd or the 3rd metacarpal probably doesn't matter what you put them in because they're probably going to need surgery anyway because those tend to be unstable and they tend to angulate. The 4th and the 5th tend they angulate as well, but you can functionally you can live with a bit of angulation like a boxer's fracture. You can live up to be functional with about 60 degrees of angulation on those boxer fractures. So the 2nd and 3rd metacarpals tend to need surgery. So for volar splint, again, pretty straightforward. Just paying attention to really keeping the MCP joints free, keeping the wrist a little bit extension. So most distal radius fractures, this is fine for. You can do a sugar tongue, especially if there's an ulnar component to it. We're not talking just an ulnar styloid, we're talking more like distal ulna, like a big ulnar head fracture, then I would consider a sugar tongue, but for just like a straightforward Colles fracture, you can just put them in a volar splint. That's totally fine.
You want to make sure too, the thumb
Their
is,
thumb and their fingers are free.
it's okay for the thumb to be free and the fingers.
Yes.
Yeah.
Yeah.
You want to show them like maybe like cutting a hole for the thumb. So as they're wrapping,
Oh,
because I think we see a lot of times people, you don't know what to do when you get to the thumb. Everybody's like, what am I doing here? Because we got,
like ace man.
Yeah.
Okay.
yeah.
So, just for wrapping like a volar splint.
And in the volar, it's okay that they have that much like thumb.
Yeah.
Okay.
Yeah. So, yeah. Again, fingers like to move. If they're not broken, I get fingers moving right away. So again, for a distal raised fracture, you don't need to splint all the way up to the fingertips, and you don't need to splint the thumb. Scaphoid fractures are a little different. I would probably include the thumb.
Okay.
What if you put them in a thumb spica?
I put them in a thumb spica. Now,
Gotcha.
for the thumb, sometimes if you're using a raised bandage and you get to the thumb, you're like, you can hook it around the thumb by making a small, like that. And just kind of doing something like that. That's fine too. I tend to do this. I tend to hold it so that it kind of keeps the fingers free and doesn't compress the web space too much.
That way you're wrapping around and it makes it a little prettier on the thumb. I notice a lot of people, you gotta get to the point around here and you don't know what to do. And you have extra, and then you start bringing your ace wrap out into the fingers, and you don't want that. You want those fingers free and not, because patients will, I mean, I know they go home and they take their splints off and do crazy stuff with it. We know that too, but especially the really compliant ones, if you wrap their fingers and make them like this, they will leave them like this until they see us in the office. And they're like, this is the worst thing I've ever experienced, and they really need to have their fingers free.
Especially older or
Yes.
fingers like to move. They don't like to be immobilized because they can get stuck. And even if they don't have fractures in the fingers, they can get really stiff. So that's that. I'll demonstrate a sugar tongue. You guys know what sugar tongue splints are? So sugar tongues are great for, again, like any bolt bone, like a distal radius, distal ulna, mid shaft, or even more proximal. I like a good sugar tongue splint. So typically for that, because it looks like 15s aren't going to be long enough, so it's going to be a 5 by 8.
Yeah. Probably not. And as you're wrapping the web roll, it takes a while to get some experience with wrapping the web roll. Can't say that very well, but you want to you can pull it and you give a little pull and it tears. I mean, you notice that it tears, and that's okay. If it tears, it doesn't have to be perfectly flat. I know everybody always talks about that, like your web roll has to be perfectly flat. It's never flat, and that's really only if you're going to cast them. You guys are never going to cast anybody, so you don't really need to. It doesn't have to be perfect, but you do want to I usually say a good is 2 layers of padding.
Yeah.
That's what I think, and as long as you're putting that on the correct.
This stuff is pretty well padded. So.
Yeah.
So for a sugar tongue splint, again, you're preventing rotation of the forearm. So that's really what it's used for. The only caveat about web roll and sugar tongue splints is padding the electrodynamic process of the elbow. Honestly, you can never put too much web roll there, because that's definitely can become a pressure point even in a sugar tongue splint. So let's just say for demonstrations purposes, I usually web roll up to here, even for a sugar tongue. So I'll just web roll the whole thing down. Again, keeping the fingers free. And having the forearm at neutral, not pronated, not supinated, just at neutral like this when you're putting your sugar tongue. And then you're trying your best to keep everything free, the fingers, I mean. And then you really, again, this one's these aren't the best to do sugar tongs, but, the more you can kind of mold it behind the elbow, the better for that. And again, so this is where I use plaster. I use rolls of plaster, but I don't think you guys have that, which is fine. But a sugar tong, this is probably what you would use, is a 5x30. I didn't see a 4x30 in there, but that's okay.
And there's no negative, you don't lose points if you put this on and just put some web roll around
Right.
on the outside to initially get it to hold. Especially if you don't have help. I know how this happens. It's, it's busy. Only one of you is in the room and you're trying to do all this and hold the hand. If you can get that on and just wrap one bit of a web roll around just to hold it in place.
It makes really
Initially, it makes it a lot easier because you can wrap the whole thing on the outside with one layer of web roll just to kind of get it set and then wrap it around with your ace wrap. Nate may not like it because you're using up all of the prompt care's web roll, but your splints will look prettier, your patients will be happier, so you can tell them to forget about it.
So that's the sugar tong. And then
Amy loves the arm with that, because then
Yeah,
usually, okay,
Yeah.
90,
Yeah.
then put them in an arm sling with
Yeah,
the sugar,
yeah.
just so.
arm sling for anything really,
Okay.
just raise fractures, any elbow, any sugar tong. The long arm splint, again, you're gonna web roll almost up to the shoulder and web roll all the way down. Again, really paying attention around your elbow, the olecranon process and the distal humerus. And then again, forearm at neutral. I'm trying to do this word. Pretend it's cut and it's nice and pretty. And essentially that's your long arm splint. So that's a good splint for olecranon process fractures, any sort of elbow injury, minus radial heads, I'll get there. Distal biceps ruptures, triceps ruptures, anything you're not sure of around the elbow. That the long arm splint is a decent, like, all around go-to splint. Because, you can, especially with this length, you can get the forearm at neutral. It's going to keep the elbow at 90. In fact, I'd probably prefer you guys doing this over the sugar tong, but whatever works. Let me get to radial heads just real quick. So radial head fractures do not need to be splinted most of the time, as long as they're non-displaced or minimally displaced and there's no evidence of dislocation. So typically you can see those, send them home in a sling. We'll see them, and then we usually get those moving right away. They think we're crazy when I tell them you do not need a cast, because elbows are very unforgiving. They don't like to be immobilized unless absolutely necessary. So I get almost all of my radial heads, isolated radial head injuries moving, as long as they don't need surgery right away, and then sometimes therapy. Coarctation?
Coarctation, I think that's coming downtown.
Probably, but
Yeah.
just for
You can show them if you want to.
real quick.
I would also say, when you're putting on the long arm, the biggest problem I think in the ED and prompt care is you guys are busy and you put this on and the patient's like this, real pretty, and you leave the room. And then over the course of 5-10 minutes, they're like this. And then they can't get in their sling and it looks, and then you're sending them out and it's all herky jerky. So I always just take that time to try to hold the patient at 90, talk to them.
Or you can put them in a sling right away.
Yeah, and you can put them in the sling right away and make sure they're at 90. But if you're there, don't leave, let it get hard. There's so many times splints have been perfect. I know, because I watched in the ED residents and people do it. They put on a splint and they walk out of the room and it's beautiful, and they forget that it takes a little while to get hard.
Right.
And we even do that too. We get impatient. Everybody does, but I always say you just stand there and spend the time. It'll look better, and you won't get that mean call from us saying that splint was terrible.
Just for completeness purposes, but I agree with Kevin, if you're putting on a coaptation splint, we probably deserve a call for that. So coaptation splint's really for either a Holstein Lewis, distal 1/3 distal humerus, or midshaft humerus fracture. It's really like a stirrup for the upper extremity. It's a stirrup for the humerus, and it's literally this. So I'm just kind of wrapping it around. Kids, actually, a coaptation splint for kids is never a bad idea. They've got like a mid-shaft humerus.
Yeah.
Anything more
Wrap the
proximal?
vertebral all the way up,
Yeah.
wrap in the armpit really well. Yeah.
Anything more proximal than that, you do not want to use this. So like your little old lady that falls, that has like a humeral neck fracture, this becomes a fulcrum. So that's never a good idea. So really just like a proximal humerus just needs a sling and a follow-up with us.
And then just some helpful hints I find for putting on these splints is if, especially upper extremity, if you have somebody who can help you or the family. I mean, I know sometimes that's all you got is, mom's there. I always say, I'll just say, Mom, if it's a wrist fracture, can you hold these two fingers and just hold their arm kind of out to the side? And as they're sitting there, they can hold them, and then you have ability to put it on. I know a lot of times the patient's like this and you're trying to fight to get it on. If you have somebody to help you or even the family, they just need to hold two fingers and let gravity. The patient actually, as they relax, it'll feel better because you're not putting any stress on that fracture. So that's always good. And I mean, that's how we reduce some of our distal radius fractures. We just hang them up, hold them, and allow gravity to do all the work for us. So if you have somebody holding on to that helps. Because I know I do splint sometimes in the ED, and I'm always like looking for somebody just to hold two fingers. So that's really what you need. I need somebody just to hold these two fingers, and it helps out a lot.
Does the patient tolerate that really well? Like they don't need any special pain meds or anything?
Just need to. Down a little bit.
Uh-huh.
Yeah. I mean, if it's so, I mean, really like a distal radius fracture, right? Like honestly, sometimes putting a little bit of traction kind of straightens up the fracture just a bit. And you're not going to get a great reduction just by gravity, but it can help a bit.
Mm-hmm.
People do
I was gonna say, I
okay.
did it a couple of weeks ago and the patient like literally had instant relief and he was like, oh my gosh, can you keep doing that?
Yeah.
Yes.
So if you want
Before
to,
you
you guys
put it
have
on.
weights here?
We don't have weights,
Yeah.
but I'm familiar with the finger traps and the weights and doing that, but he had like instant relief. He was like,
Yeah.
don't put it down.
If you just kind of, I always say you give them a little bit of okay anesthesia. You grab a hold of their fingers and you're kind of talking to them and sweet talking, and this is going to help you. It's going to feel better. Initially, it's going to hurt because we're moving, but when we get it up here and you just let that arm go, and my usual joke to them is that whoever my assistant is that's helping me, I would say, Missy hasn't done her upper body workout today. Let go of your arm, let her hold it. She's strong. She needs this workout, and just relax. Let that arm go dead while they're holding it. And then it will feel better for them. And you just kind of tell them it's going to be okay.
Yeah.
This is going to be okay. And you can put a better splint on them and make sure that it's, not too far up into the fingers and all of those things. And you have time, I always tell newbies who are doing, when we train new PAs, I tell them, this will get hard without getting wet.
Yeah, it's already like this is.
So if, you have a kid who's moving around and this is going to be a hard thing, you don't even have to get this wet. You just have to be willing to commit the time to hold it on. But that gives you plenty of time to wrap it, to get it perfectly positioned. I know a lot of people talk about, well, use hot water. Well, it gets hard really fast. And if you're halfway putting this on and it's all cattywampus and then it's hard and you're, as you know, and probably experienced, it's so unforgiving. You can't get the splint on right and it looks bad, and you just like want to leave the room and get out of there as quick as possible because you feel like you look like an idiot. But cold water or no water is better.
Yeah, cold water, I mean, it will set up, it just takes time.
Mhm.
Hot water is going to be done in like a second.
Yeah. So you kind of want to get that good feel for that and not putting it on so fast that it's instantly hard. Because it's without good help, somebody, especially if you got mom helping you, she's worried about what the other kids are doing, or dad's, passing out in the corner, whatever, all those things that are happening. So you want to try to give yourself plenty of time to put it on.
You guys have questions about upper extremity splinting?
So I have a question, just maybe for clarification.
Sure.
So there's always the push for same day or next day or follow-up.
Yeah,
Is there anything specific, like with just a general fracture? Like
Sure.
guidelines for patients and expectations for them
yeah.
for a phone call, once a referral's made, how
Right.
soon should they expect to be called and maybe seen by one of you guys in the office?
It depends on the age, honestly. We like to get kids in fairly quickly, especially with displaced fractures, because kids heal like the moment you send them out to parking lot. So the quicker we can see those, especially with a fracture that needs to be reduced, the better. For adults, on average, now it depends on the fracture and the injury. I mean, in general, if you've got a displaced distal fracture, if I get to it in the OR that needs surgery within 2 weeks, that's fine. So typically, if you call, that day or the next day, in general, for the most part, for upper extremity stuff, we can get it seen within about 48 to 72 hours. So I would, I think it's age dependent.
Yeah, because I get a lot of in-basket messages from
Yeah.
my chart surveys that received the call. And I've been trying to let them know that, hey, listen, we're going to put in a referral. Someone will call you. We encourage you to call them if you don't hear anything within the next maybe 3 days.
Okay.
If it's a Friday, if you don't hear something by at least Monday or Tuesday, give the office a call.
Yeah. So Monday mornings tend to be hectic because
Okay.
all of those referrals come in and we've got a queue. So I think that's a great idea. Put the referral in, have the patient call our main number, Monday morning or the next day or whatever's convenient for them. If you guys are really concerned that there's going to be difficult follow-up, call me. I don't care if I'm on call, just call me. It's fine. You can write chart message me. I don't really care. I'm happy to give advice anytime.
Yeah, I think that's also, I mean, I know a lot of the docs, if you send a MyChart message or a staff message, I don't know if the providers know that you can, like, you get in the patient, you can send a message, that Dr. Rashid's on call. And she loves to get those messages because then on Monday morning, she can say to her nurse, hey,
get this patient
get these,
seen.
I need to see this patient right away, or this patient can be seen on,
Yeah, I can also triage a little bit over the phone, and it helps my schedule a little bit too, because I'll be like, okay, this needs surgery. I want to see them tomorrow so I can get them into surgery on Wednesday because I have time available. Or this doesn't need to be seen. This doesn't need to be seen right away. It doesn't need surgery. I can see them Friday instead.
So as providers, you can, if you know who's on call, you can send them staff messages.
Mm-hmm.
I know Dr. Maxey anytime will respond to a staff message, even if he's not on call, he'll give you advice. Yeah,
I will.
most people
As
will.
long as I'm
Yeah, the PAs, when we're on call, if you wanted to, you could ask find out from pals who the PA is on call for ortho. Especially if you sent something out and you're not maybe sure, but you splinted it, and you think it's okay. How soon does this need to follow up? Those kind of things. It lets us know, and we can get them either fast tracked or something else.
Any questions? Do I do lower?
Yeah. Yeah, lower extremity. So really for lower extremity, you want to be the model,
Yeah.
man?
This is
Hey, here.
in
Hey, you can sit up here, bud. You get to sit up here on the table. Other way. Come on this side, yep. So
He's an
Aiden,
empathetic preteen that's already.
you want to take off one of your shoes? Can you do that for me? Aiden, maybe he broke his ankle. We don't know. They got an x-ray, but he's hurting, or maybe he did break his ankle. So really, most of the fractures you guys deal with are foot and ankle things. And when you're thinking about putting on a splint on a foot and ankle, you want to, so there's a couple things. Putting on and this is we're going to do a leg splint. That's really the main one that you guys are really going to use a lot in the prompt care. If you're putting on a long leg splint, they probably need to come down to the big house, and they're gonna need something. Putting on a knee immobilizer for like a patella fracture or those things. I wish I could have had one down here. I would kind of show you how to put that on a little bit better.
Do you guys
So-
have gloves here?
Yeah,
We do.
What
Yeah.
colors?
and I think we all put it on different. So it would be nice to see it. put
Yeah.
on.
Would be nice.
Well, we all put them on different too, but I'm gonna show you the correct way because it's the way I do it. But
The year that I worked in, we used the Scotch cast to do a knee
You
immobilizer.
can.
you can, yes. Yeah, you can do two long splints on either side.
Sometimes there's a fitting issue with those preformed on
There,
it.
yes.
That lay,
There can be
They get
people who
weird.
have really big
yeah.
thighs, and so that
It's
makes it a little harder to do.
Yeah.
Yeah.
Yeah,
So-
sometimes that's not a bad option. They like to, yeah.
Do you like the, okay.
So when Aiden, he's broke his ankle here and he's all tender and worried about it, you can do a couple things. One, you can have them just hang their foot over the edge. And you gotta kind of do a little bit of okay anesthesia, kind of talking to them. It's gonna be fine. If they will not move and they're gonna lay in bed and absolutely not get up, I always just have my assistant, whoever's gonna help me, hold on to the big toe and hold underneath here. Just tell them relax that whole leg, let go. Aiden, you trust me, man? Yeah. All they gotta do is hold on to the big toe. That's really the most important, because an ankle always wants to, not always, but 99% of the time, if it's gonna dislocate, it's gonna go lateral. So if you're holding on to the big toe, you're actually bringing it medial, so you're gonna keep the ankle reduced. I think that's one of the biggest problems, is everybody kind of wants to just leave it neutral, but if you have a little bit of medial pull to the toe, it kind of keeps the ankle reduced. And then you also want to, yes, you got people.
Does any preteen or teen boy have clean feet?
No, they don't. They don't. And getting them clean before you put the splint on is hard because they're crying. But, you know, especially if they're between the ages of 16 and 21, they're the males, we're terrible. But I always, when I take my Weber and I'm wrapping, I always start here distally, and I leave the toes out because you don't want to incorporate the toes. You don't need to incorporate the toes. And then as I'm wrapping around, I will come around and I want to make sure that I put like 3 or 4 layers around the heel and the ankle bone here. So you can just really wrap this up a lot. And then if you're going to use this one, just come out.
Yeah, padding along with calcaneus and the is important.
Because this is the splint that people might be in, they might not follow up. It's a homeless person, they're gonna walk on it or something, you know.
Simple fracture into a fracture.
And then, so I wrap 3 or 4 right around here. You can even take your web roll if you want. Say it's a little old lady and you're really worried about her skin. You can just take the web roll and just pull it and then tear it and put 4 or 5 right here. You don't want to get too bulky here on the top because it prevents you from dorsiflexing the foot. And then approximately here, I always wrap up. I kind of put my hand back here and feel the back of the knee, the crease in their knee. And usually if your assistant's holding it, if they're up, they can kind of hold and tell the patient to bend their knee. And you can wrap. I usually wrap 2 or 3 times up here. And then I work my way back, I work my way down. But you want to wrap and kind of make a little bit of a bulkiness up here. This slide, it's a little bit too big for him. So when you wet this, obviously, and you want to wring it out, and then you can take, and your assistant, when they're helping you, if it's a mom, it's going to be a little hard unless she's an orthopedic surgeon, and it helps a lot. But they can just hold on to here, and you can actually take. You can take and actually wrap some web roll around here just to hold it in place. as a cheat, especially if you're not trusting who's helping you. And you can also bring this up, and you want to keep this low enough that the patient can bend their knee. So that's actually a little high. I want to go a little lower. And so as they're holding that knee, they can keep it bent. And so you want to make sure that it's nice and bent. You can hold this back. If you don't have scissors, I would cut this off if I could. And the one other piece of advice, I'm going to steal this. It's the same thing that Dr. Rashid said about what happens is this all sticks out here. You can see this, and this gets hard and pokey, and oftentimes patients, as they're flexing, it'll work its way up in there and really bother them in the back of the knee. So you just want to reach in here and you can fold this down and make it so that it's covered up so that you have plenty of good cushion on the back there. You can even fold it down a little bit as you're wrapping it up. That'll also work well.
Does it if like I usually cut I fold that down and then cut it shorter and then put the pocket back up.
You can.
Yeah.
That's great.
It doesn't poke. Have you guys had any?
No.
I say if you just fold it, it's fine.
Yeah.
You just hold it, it's fine, but you can do that same thing. And as long as you've got the padded side against the patient. My assistant's failing now. I would probably, for Aiden, I would want I usually use a 3-inch and a 6-inch web roll. That's just a good idea, just to have 2 of those already open and just plan on it on every short leg splint that you're going to put on somebody. And then you wrap it. And the absolutely most important thing of this whole splinting process is making sure that it's not in the back of the knee and that this stays at 90 degrees. And so what often happens is you put this splint on, and what happens? Everybody leaves the room, and the kid or the patient sits there, and they end up in ballerina position. So that makes it hard to use their crutches. It also is bad for your Achilles tendon, because if they stay in this too long, it'll shorten up that Achilles tendon, and then they'll have some real hard problems getting that stretched back out. And so you want to make sure that you're putting them in 90 degrees, especially kids, little old ladies. You want to make sure that you're keeping them at 90 degrees. And they'll fuss, and I usually say, this is going to hurt a little bit, and I just kind of give it a little push, and I hold it here, and I'll usually have them laying on the bed, and I'll just kind of start telling some jokes and trying to entertain them a little bit, distract them, talk to them about something else. But you want to make sure that you just got the toes. This little toe here, you want to make sure that it's not pressing on here. You can actually take and fold this down, roll this over if you want. If any of it's sticking out, use the ace wrap to kind of cover that up. It also helps if you just wrap first with web roll, it'll see. And if you're helping somebody and you're holding the toes and you notice this, you just want to make sure that you're keeping that little toe. Because sometimes people will grab and really squeeze hard here, and then the little toe ends up getting smashed in there. Patients will really complain about that. So the other kind of short leg splint that people like to put on is a sugar tongue splint. And it's kind of the same thing with the upper arm. You want to make sure that you pad it really well and that you put the splint on. This would not be a very good one. I would want to use the whole length, and you want to bring it up at least up to here on the patient. So for him, starting to get there. And And you want to make sure, of course, this is going to be a little too hard, but you want to make sure that you mold this around here and bend this down. You can almost make it like into a cast. So you want to be careful that you're not pinching their skin in between this if you're making a sugar tongue, and then you just wrap this around. Some people like this a little bit better. They feel it gives them better stability in the ankle. The problem is that oftentimes people don't get it molded very well around the ankle. I was like a posterior mold splint. I mean, truly, if their ankle's dislocated, they're going downtown, right?
Yeah.
So that's not going to be your thing. Unless you want to be compassionate and kind and throw on a quick posterior mold splint so they have some kind of support while they're heading downtown. I would always encourage that if you can. You can just splint them where they are, but it at least makes them feel better so that when they do get up to transfer or whatever, they got something that's supporting their ankle.
Sugar tongue would be like preferred over the posterior.
But I mean, in reality though, like with that, I would be concerned about pressure points on either side of the ankle.
Okay.
I think the posterior mold, short leg posterior mold splint is the best for ankle fractures, foot injuries, any of those things. If you think I know sometimes patients, you'll think they have a sprain, you'll put them in one just to kind of see, especially kids too. If their growth plates are open, we don't know. So we took an x-ray, but they're really tender. It doesn't hurt to put them in a splint, get them some orthopedic follow-up. They may need repeat x-rays, all of those things.
Just about grandma, if she breaks her foot or ankle and she can't use crutches safely, what do you guys recommend we do in those situations
Downtown for.
automatically?
Or a walker. Grandma, they can use a walker. If as long as they can go non-weight bearing. Grandma oftentimes can't use crutches. And it's hard for them on their shoulders. If you're on the weekend, my big suggestion is tell patients, maybe they're going to say, hey, we're going to take grandma home and we have a walker. Or you can also tell them, I don't know if any of you go to Goodwill or Mission Mart or any of those places. There are a ton of medical supplies that people have just dropped off. You can get walkers, crutches, canes, all those things at Goodwill. They don't necessarily have to go to Walgreens or anything, everybody. But I mean, if they want a new one, yes, but you're okay to tell them they can try a walker.
Okay.
They just need to be non-weight bearing if it's a non-weight bearing injury. You guys have air cast boots?
We do, but we kind of got away from them. I mean,
Well, that was just the ankle.
oh, yeah.
That one, yeah, we didn't have
Oh,
that.
yeah, we only have the stroke.
The
Yeah.
air cast stirrups, yeah. Yeah, those stirrup splints are,
So this is question. So a couple people like asked, is there a time that would be okay if we ordered boots for a patient to, I mean,
Do you have boots?
we
No.
don't, but I mean, if it's something that we could probably
So
have.
we get
I
patients
can-
always
I'm able to order that.
The problem with boots is they're extremely expensive.
Yeah.
And insurance companies don't cover DME.
Right.
like,
And a lot of these patients don't have the money out of pocket to pay $200 or $300 for it.
That's 100% correct.
Well,
Even some, like Humana doesn't cover a lot of DME. They don't cover like cock or wrist ones. So I get calls like, I spent $110 on the wrist one, but I could have gone to Walgreens. So
we've gotten away from the
Yeah.
boots for that reason, but I mean, we can always write for it, I guess, if they want to pick it up and
Just
then.
think about like but that would still be a weight bearing, right?
yes.
yeah.
Yeah.
We sometimes will put a person in an air cast boot and maybe have them non-weight bearing for 3 weeks, and then we'll let them start bearing weight in the air cast boot. My advice to you would be, if the patient asks for them, the first thing I tell them is that they can be very expensive and your insurance may not cover it. And you might not need this air cast splint for a long period of time. And so you're really wasting money. Leave that to when they come see us if they need an air cast splint. That would be the best way not to make people really mad. Because you'd be mad if you pay $200 for an air cast splint and you show up at the orthopedic surgeon's office and he says, hey, there's no real fracture here, or it's a fracture that you can just go with it. It's a metatarsal fracture and we say, hey, just wear hard sole shoes for a week and then slowly advance your weight bearing, and you've spent $250 for an air cast. You're going to call prompt care and scream and yell and
Nate will.
yeah, you're going to call Nate. He's going to yell at Nate.
I just worry about people that we put them in walking boots. I'm afraid they might not follow up with ortho, because I've got a couple patients, who have wanted those.
Oh, yeah.
And I was afraid if I had one, they wouldn't follow up with the ortho.
The battery's running low.
Yeah.
So, Kevin, before we move on to anything else, so there's in the past we've had some concerns raised from Joy Ortho for the kids ortho in regards to a kiddo that had a pressure ulcer on his heel after being splinted. Can you go through, kind of talk to us about education on how they should be propping that leg? Obviously, you want to elevate a little bit, especially if there's some swelling there. How can you show everyone how they should rest their leg if they're going to prop it up?
So the first thing is when you're splinting them, put 4 or 5 layers of web roll around the heel and make sure you have the correct padded side. The only time I've seen an ulcer in the heel is they're in a hurry and they put the wrong side. And I know everybody says, well, how can that happen? How could you put the wrong side on? But it happens. So you always want to check and make sure you have the padded side on. And then when you're educating them, you want to make sure that as they're resting, I don't know if I want to keep this leg up here. As they're resting, what happens is they just leave their heel and their heel's digging right down into and it doesn't matter how much web roll you put on there, that heel's going to put all the pressure on it. So you want to put, yeah. Or if they, the kids, sometimes they don't want to move, it's hurting. You want to put a pillow underneath here and leave the heel suspended in the air. And so tell the family that to leave the heel suspended in the air for all these ankle fractures. You tell them, I want you to ice and elevate. And when you elevate it, tell them to leave the heel out. And so it doesn't have a pillow or it's against the bed. You want to put pillows underneath here so that they will keep it up off. They can also roll a towel and put underneath the splint so that the heel's up off the bed. Those are the 2 real things to do, because elderly patients, kids will just leave their heels on the bed or couch or recliner and just dig a hole right into their heel. So, yeah. If you are afraid this patient's not going to follow up, you're about to put the splint on, that's always I know we call and probably fuss sometimes, and some patients they don't have the money, they don't want to call, so they're wearing their splint for 2 or 3 weeks. If you get that feeling, adding a little bit of extra pads of web roll, especially if you're doing the elbow, the heel, there's no negative part to that. And remember, you can tear the web roll and just make a nice big heel pad. You can also incorporate an ABD. You can take an ABD, put it in there and wrap web roll around it, so it adds even a little bit more cushion to that.
I think the ankle, the heel, that's by far and away more, that gets more stress than the elbow, but the elbow still.
Yeah, well, they're not going to show up for a little while, so you're not saying. It can,
Our patients never.
yeah, they always come right away.
Right away.
So, yes.
Is it a thing to go too wide? I know sometimes sizing wise for posterior legs on kids, it's hard to get the length.
Yep.
Is there like a too wide of a?
Well, so the big thing that you want to worry about is when it's too wide that you're squeezing the foot here right around the toes. It's not bad here at the ankle or up here, it's all at the toes. You're like squeezing. What happens is that the patient says, my toe is killing me. And then, so if you're going to do that, you just want to make sure you kind of peel that away, because there's no fracture here in the toes. You can actually get in there with your finger and just kind of make sure there's plenty of space around the toes. Does that make sense? You're doing good, man. This is going to be So usually knee immobilizer, they're very rarely is the patient perfect for the knee immobilizer. It's usually going to be like Aiden here, he's too small for this knee immobilizer, or the patient's too big for the knee immobilizer. But if you're going to put it on, yeah. So you always want, the knee immobilizer will always slide down. In fact, you tell the patients all the time, if they get up and walk with this, they can bet that the knee immobilizer is eventually going to end up there because gravity does it. And so you want to make sure that you're putting it up high on the leg. And then you can take and actually, I always take these side. I'm going to actually use this immobilizer. Why do we peel these off? And then I take and I fit this onto the patient and use these two extra pieces to kind of hold them on. Okay. If you're noticing that you're getting a lot of fabric over this, you can actually take and cut off part of this so that you can not have so much redundant padding on here. Because sometimes you get a really little kid, or a little grandma who's got a really little leg, you're just wrapping around and around. So you can take and trim this, and you can even tell the patient if it feels like it's a little redundant at home, if they leave their leg straight, they can actually cut it, trim it a little bit, and it'll make it feel better. I'm not going to trim this one here, but take and just kind of wrap it. And then use these Velcro. Everybody asks, why do you have these? And these are so that you can take and put it on here so that you can make sure that you're kind of on, right? Everybody see that? And you want to spin around and show them. So see how those are on there? Because that kind of holds it in place. And then you can spin back around. You want to take and you want to put these perpendicular to the leg. And you want to make it snug. And as I'm putting these on, I always tell the patient, so this is going to, as you walk around, this is going to slide down. So occasionally what you're going to have to do is lay back down, unloosen this, pull it up, and then put it back on. And you can see we've kind of pulled in this, so you can adjust these bars, but you want to have it perpendicular. And as Aiden is at home and it's going to slide down, you just remind them again, it is going to slide down. You just put it back up. Sometimes I'll tell patients if I'm really worried about them that they don't, I say, you know, when you're sitting around and you want to loosen it, say it's too tight, but when you get up and walk on it, especially up here at the top, take these off and cinch them really good. And you won't have to adjust it so much. So cinch them down, just tell them they can make them tight so that as they're walking, that it won't slide down. And then when they're sitting in bed or whatever, you can loosen this. It's not the end of the world. Just tell them, if we're putting them in the knee immobilizer, tell them just don't bend the knee, like if you have a patella fracture or something. If they can't fully straighten their knee out, there's the little bars in the back here. Let's say Aiden's got a big swollen knee, he's got a patella fracture, he can't quite go straight. And you want to be extra special, be good. Wouldn't be Aiden, normally it would be a lady who's got a really big leg. You can actually take in these bars and you can bend it a little bit and shape it so that it'll give a little bit of a bend to them. So see, you can bend it just a little bit and then it'll fit a little bit better and then cinch it down. And slowly over time, as their swelling goes down, you can tell the patient, you'll be able to cinch it tighter and tighter. That's also what happens is they can usually cinch it a lot tighter. So any questions?
No, if we put them in an immobilizer, is it something they'll always need crutches? Is that, or are they okay to bear some weight if they have an immobilizer?
No, we don't have.
Okay.
Mm.
You need to see really quickly, but.
Even a patella fracture, we'll let them bear weight on that in their knee immobilizer as long as they're wearing their knee immobilizer. We don't want them bending. And most of the time I would probably give them crutches, just because they're for comfort and for walking around. Initially, most of the time they're going to leave your prompt care and they're not going to really want to bear weight because they're not going to believe you right away. I think that's usually what we see is when I tell them like, hey, you can bear weight on this, they'll be like, no way. So you give them crutches and eventually tell them use their crutches and bear weight on it. So it gives them some protection too.
Mm-hmm.
And then the knee immobilizer, they should pretty much wear that all the time, I mean, even at nighttime, because you don't know what they could be doing.
Yes.
Rolling around in bed and stuff.
In bed, definitely.
Yeah.
If they're sitting around on the couch watching TV, they can open it up. And a lot of times patients will say, you say, well, put some ice on your knee too, because it's swollen. And they say, well, how can I do that? You just have them open it up and they can put the ice right on it. But anytime they're going to get up and walk, they should cinch it down and remind them, make sure you cinch it down tight. So the ones that are the problem are the ladies with, unfortunately, really big thighs, that it's just kind of heading in this direction, and the knee immobilizer will slide down to their ankles. And some of them probably it happens by the time they get to their car from leaving here. So I usually tell them like cinch it really tight, and tell the patient this is going to feel too tight right now, but when you get at home and you're not walking, you can loosen it up. So, but they'll tell you all the time. The other thing is that I was going to say about kids splinting. Kids are magicians. Sometimes you put a splint on them and they will, somehow they get the splint out and the ACE wrap and everything's still intact and they're like handing you the splint. That happens to us.
Happens when we cast.
Yeah, that happens when we cast them. We put on the best cast in the world and the kid goes.
I had a 2-year-old I saw 3 times in 1 week, but she kept doing it in the meantime to get into it. She just
Between the ages of like 12 months and 3 years old, they can get out of anything. Even if you have like a long arm with a nice mold and it's nice and straight along the ulna, they get out of it. They just do. They have chubby.
Escape artists too. Their bones bend and then all of a sudden, boop.
And that's what I tell parents too. I'm like, their kids, exactly. They will get out of this. That's what they do. So if they do, relax, just call us. No big deal. We do it.
Yeah. And most of the time, the kids, if it's really fractured, they won't escape because it hurts. They won't mess with it. It's the ones that it probably wasn't fractured, but they were a little tender and you guys put them in and then the patient took it off. And I tell patients too, if the ACE wrap feels a little too tight on any of your splints, you can loosen it. Don't take it all the way off because it's hard for them to get it back on. So I tell them, you can loosen it up a little bit and rewrap it. Oftentimes ankle fractures will say that. I would encourage you, ankle fractures, tell them, get home, get your foot in the air. And getting your foot in the air is not this, actually laying down, toes above the nose. So that's how you get rid of swelling. It's toes above the nose, hands above your heart so they can stack pillows up. So wrist fracture, because they'll all call 2 days later and say, my fingers look like sausages. And they've been like walking around with their arm hanging down, So you tell them to stack some pillows up and get your arm up and watch TV. Watch your Netflix or whatever you're going to do with your arm up to above the level of your heart. What else? Any other orthopedic questions?
Well, I think you mentioned earlier, I meant to ask him, did you say about like if you have a bicep rupture, should you, because I typically don't think we usually do.
Yeah, I feel like we've always just put them in slings.
It's fine.
Yeah,
Yeah, that's fine. If you're,
so I just want to make sure we're doing that right.
it's fine. I'm okay with that, honestly. With distal bicep ruptures, that's a bit time sensitive because most of the time we get an MRI for that. And there's like a 3-week window to get that fixed.
Yeah.
So, with that, if you want to call us about that right away, order the MRI of the elbow. You know, it's sometimes helpful when they're ready to come in, they've got it diagnosed. A lot of times you can diagnose it just by physical exam.
Right.
If you don't feel the distal bicep, it's nice and swollen and bruised.
Right.
But sometimes there's some question because you can feel the serous fibrosis, which is small kind of tendinous structure that kind of helps support the distal biceps, and you can feel that, and you're not sure if there's like this is a partial distal bicep or whatever. So getting an MRI sometimes can be very helpful.
For Achilles tendon ruptures, do you want us to like splint them and then same kind of concept?
Yeah, you can, well, that's actually one time that you can put somebody, leave them in ballerina. So if you want to, because maybe it's just a partial tear. And so when you put them at 90 degrees, you're stressing that. I probably should have said that sort of set my mind. But for the most part, any fractures, you want them 90 degrees, but Achilles tendon ballerina is okay. That's when I say that, that's just putting them down so that their toes are down. So they won't like you very much because it's hard to walk them with that splint. They got to hold their leg up. And it's usually a man, so we're kind of weak and wimpy. So
Post-op shoes, those are just for, you don't,
I
right,
feel like the patients are more demanding of those.
Yeah.
You would probably use them. I mean, you use them, but
they use them pretty
it seems like they're the
often.
ones that want.
metatarsal fractures, yeah, they usually do because they don't want a big splint put on them. And you can go ahead and do that. If they have multiple metatarsal fractures, you know, like they fell off something and they smashed their foot and they have multiple metatarsal fractures, a splint is a much better way to go. One single one with a post-op shoe isn't going to be the end of the world. A fifth metatarsal, I should say, we splint those too. So, because a post-op shoe, they want it for their convenience. They're just going to take it off and only wear it when they want to. Toe fractures, big toe fractures, those things you can put them in the post-op shoe. Any kind of toe fractures, putting them there, they'll make them feel better. Yeah. Mhm. So. Good questions.
Yeah,
Yeah.
good. Thank you for that question.
Yeah.
That was,
Yeah. So my biggest thing is when you're putting on the splint, just plan on initially, especially if you haven't put on a lot, just go in, try to be relaxed, get them relaxed, and then take it slow. I always say I always take in all my stuff. I think about what am I gonna need, make sure I got ace wraps close by, because you know, if you're holding and then, oh man, I need another ace wrap and there's nobody to help, and then you leave and then Aiden's here like, you know, messing around, taking it off, messing with it. So just
You have
kind of come
buckets?
in. Yeah, you have a bucket?
You have buckets in front?
No, you have a sink in each room.
You do,
Okay.
okay. A lot of times, like, when we're splinting and stuff, we have buckets, so I usually put everything in the bucket that I need, like, you know, cast padding, like, you know, and that way it's right there.
Yeah, because that's the thing, is that when you're going in there and then you need something and then, you know, you're like, hey, can somebody?
Then you can put your
Somebody-
bottle. So go ahead and sink, working all the way to the patient.
Mhm.
Yeah, but they make a good point.
She orders some buckets.
You know, that's
Put it on the list.
You don't necessarily have to do that, but I encourage you to just think about, what do I need? I'm putting on this splint. I need at least 2 ace wraps. Pretty much every splint you put on, lower extremity, you're gonna need 2 ace wraps. You're gonna do a long arm, you're gonna want 2 ace wraps. Otherwise, short arm, you can do 1 ace wrap. But take 2 with you just in case. You never know when you drop them and it rolls across the floor and then, mom's like, you're not gonna put that on them, are you? It's like, well, when we look at this splint 2 days from now, this kid's it's gonna be dirty, filthy cat hair, the dog's been licking it. They just look destroyed, but I know I've had that happen. Like I'm the only one in the room and all of a sudden it's on the ground and rolling away and you're like, okay, I'll be back. So just take everything with you. Plan on, being slow, getting them nice and relaxed. Tell them it's, it is going to hurt a little bit, but it will make them feel better. After you get this splint on, they're going to feel better. And so I always try to encourage patients, tell them that, you're going to feel better after this. So. You said that. What's your buddy? I'm sorry. I put you up there.
Thanks for your time. We
Yeah.
really did.
Yeah, passing on.
Yeah.
Thank you so much, we appreciate it.
Feel free to, message staff message, or sometimes I'm on the chat, operating, so. I'm happy to answer. Look at questions or
Yeah. And especially if or you see a case and you send it in and you're like, did I do the right thing? Sometimes you just want confirmation, did I do the right thing on them? I encourage you to click through x-rays, on your past. The only way you get good at reading x-rays is looking at a lot of x-rays. And so any provider, I encourage you I wonder what happened to this person. Click on their x-rays. You've already violated their HIPAA because you took care of them. So you should just keep, checking on them. I don't think if OSF gets mad at you, then I'm in big trouble because I look at all the orthopedic patients all the time. I have all the APPs. We're always like, look at these x-rays, get to know what you're looking at. It just makes you better.
Yeah, we help the residents all the time. Like I look at your x-rays when you're around, don't read, but look at them, and if there's questions, we can talk about what they speak about.
Because the smarter we make you guys, the easier our job is.
We do have to read our own before the radio.
Yes, you
Sometimes
do.
it's about 24 hours before we
Right.
get back.
Yeah, and that's fine. And I guess what I see is maybe a tendency to overread, which is totally fine. I prefer that.
But then look at them and keep looking at them, and so you know what's happening. Especially if you feel like you missed fractures. I mean, I miss stuff all the time, and so I am always like, okay, what happened there? And I go back and look at the original, and as you look at them, you're like, okay, now I see that. Yes, and that's the only way you learn.